So, up next, let's discuss some behavioral and cognitive behavioral approaches to psychotherapy. Behavior therapists focus on a specific problem behaviors and the variables that maintain them or the reasons why they're happening. So, a child who is bored may act out in school. So, knowing the cause of the problem behavior, which is boredom, can help us address the problem of acting out because it lets us give the child a functional alternative, maybe a fun project to work on when they're done their classwork. If we don't know that the child is bored, then we wouldn't be able to address the root of the problem. We might be guessing. Maybe they're hungry, maybe they're cold, maybe they're tired. This way, we can really get at the root of the problem in a much more systematic way. Behavioral therapy doesn't deal with root causes, it focuses on addressing the behavior itself. So, causing critics to suggest that since the underlying cause of the behavior isn't being addressed, the problem isn't actually being solved and will just manifest in a different way. So, if you think back to when we talked about learning several weeks ago, that was a major issue that we're just dealing with the behaviors and not necessarily dealing with anything else. Now, behavioral therapists assume that behaviors result from classical and operant conditioning that occurs in everyday life. So, take the example of a person with a dog phobia. They are walking down the street and they see a dog coming or a person walking a dog. So, they cross the street to get away from the oncoming dog. What they're doing is they're negatively reinforcing their fear of dogs because they are removing the stimuli of the dog, which is likely to increase their street crossing behavior in the future. So, a behavior therapist could create a behavior plan for addressing the problem. Perhaps we want to use a shaping procedure where the client moves a tiny bit closer to the dog every day until eventually they're touching it. And we'll see this again in a little bit when we talk about systematic desensitization. Exposure therapy confronts clients with what they fear with the goal of reducing the fear. So, the idea is that if they're continually exposed to situations that they find fearful in a number of different ways and very slowly, they'll habituate to the feeling of fear over time. So, the more they're exposed to the fearful stimuli, they see nothing bad happens. Eventually, they gain confidence in the situation and learn to master their anxiety about it. The earliest example of this was systematic desensitization, developed by Joseph Wolpe in 1958. Systematic desensitization teaches patients to relax as they're gradually exposed in a stepwise manner to the item that they fear. It exposes patients to anxiety producing situations through the use of imagined scenes. So, a therapist may instruct a patient with a snake phobia to imagine taking a walk to a pet store. Imagine going up to the door of the pet store. Then imagine going up to the cage where there's a snake, et cetera, until they finally work up to imagine you're holding the snake in your hands. And slowly gets them used to the thoughts that they fear and how to overcome them. So there's three steps. First, the therapist teaches the patient to relax through a series of deep muscle relaxation techniques and breathing exercises. Now, this step is very important because of reciprocal inhibition. So, what this means is once responses are inhibited, they become incompatible with the other. So, in the case of phobias, fear involves tension, which is incompatible with relaxation. You can't both be anxious and tense and relaxed at the same time. So, if you have these good relaxation techniques in your back pocket, you're drawing on those, and then you don't have room to feel the tension or anxiety. Second, the patient creates a fear or anxiety hierarchy, starting at stimuli that create the least anxiety and building up in stages to the most fear or anxiety provoking ones. This list is crucial as it provides a structure for the therapy. So, if you take a look on the right of your slide, you will see an anxiety hierarchy for a spider. So, starting at the very lowest level, and you see there's a fear rating for each one. So, just thinking about a spider, not great, but not so bad. Working our way up till we see a photo of a spider, looking at a real spider in a hold box, holding the box, and all the way up until letting a spider crawl on your bare arm has the highest level of fear rating. Ugh, I wouldn't like that either. So, what we do next is have the patient work their way up the fear hierarchy. So, they start with the least unpleasant stimuli and practice their relaxation techniques at each level of the hierarchy. So once they feel comfortable at the lowest level, like they feel no longer afraid thinking about a spider, then they move on to the next stage. Okay, so now I'm going to look at a spider while practicing my relaxation techniques until I can look at a photo of a spider without feeling anxiety. If the client becomes upset or gets stuck at a certain stage, they can always return to an earlier stage where they've mastered the relaxation technique and then start their way climbing upwards again. So the client repeatedly imagines or is confronted by the situation until it fails to evoke any anxiety at all, at which point we've deemed the therapy successful. Flooding is another form of exposure therapy. It's actually the opposite of systematic desensitization. So instead of dipping your toe in very slowly and starting with the least scary stimuli, working your way up, in flooding, you dive right into the deep end. You start at the top of the fear hierarchy and expose patients to feared stimuli for prolonged periods. So flooding therapists provokes anxiety repeatedly in the absence of an actual consequence. And what that does is it allows for the extinction of fear to occur. Okay. So say someone's super scared of dogs is showed a real live dog. Nothing bad happens. Okay. They don't get bitten. The dog doesn't bark. The dog just sits there very calmly. So now they've been exposed to their fearful stimuli and seen there's no consequences. Nothing happens. What this does is it results in the fear being placed on extinction. Think back to our talk about behavior. And what that means is that the fear is no longer occurring. And so a crucial component of flooding is response prevention, in which the therapist prevents the client from engaging in avoidance behaviors that they had typically used when confronted with a fearful stimuli. So consider the person with the dog phobia. Maybe if they see a dog, they try and cover their eyes if they see a dog, but the therapist would block them, would hold their arms down and not let this happen because they have to be able to see the dog in order to see, well, I just saw this dog and nothing bad happened, to break that link. With the advent and increased capabilities of technology, virtual reality exposure has become a new way to expose people to their feared stimuli. And what's really cool is that it opens up a whole lot of doors in terms of opportunity. So people can put on headsets and be virtually exposed to an experience. It can work really well in treating PTSD or phobias. So say you put on the helmet and you feel like you're on the top of a building that can deal with a height phobia. For certain kinds of phobia, this virtual exposure can be much more effective, safer, and more realistic than visualizing or actually exposing them to the feared stimuli. So I want to show you an example here. This young woman has a severe phobia of snakes. And the video is kind of long. We'll watch some of it because I think it's really interesting. And you will see the process by which exposure therapy is used to help treat her snake phobia.
The 22-year-old Mariam Doom from Venezuela, clinical psychologist Lars Göran Erst from Sweden, and Elf. He's an American corn snake. This multinational threesome is working together. Mariam helps out when Alf gets tangled in Erst's belt loops, and Erst helps Mariam put Alf around her neck. The picture looks simple enough, unless you go back in time, just 3 hours ago, as Mariam was preparing to meet Alf for the first time. Mariam has a specific phobia, a fear of snakes. Other specific phobias include claustrophobia and a fear of flying and thunder. Mariam's had almost no contact with snakes and doesn't know why she's afraid.
Since I remember myself, I remember being afraid of snakes.
She has trouble with movies.
I have to close my eyes, always.
At the zoo.
It's impossible.
And it interferes with her life.
But I have dreams of snakes. It's horrible. Like I like the scuba dive, and there's snake gills and other snakes.
Mariam is a research technician here at Boston University's Center for Anxiety and Related Disorders. Psychologist David Barlow is director of the center and a pioneer in exposure therapy. His research demonstrates the outstanding success that's been achieved in treating phobias in a very brief time period, just 1 week. Some psychologists at the center use virtual reality to gradually introduce a patient to a feared situation. But Erst bypasses all that. He treats specific phobias in just 3 hours.
What he's done, though, over the years and he leads, in some way, leads the world to this, is strip the program down to its essence.
Barlow invited Erst from Sweden to demonstrate brief exposure therapy
in the hopes that we will be better able to apply it here in the United States.
And Mariam has agreed to be treated in front of her colleagues. Exposure therapy requires that patients gain experience with the feared objects.
Unless one is willing to experience one's own negative emotions and expose them as not dangerous and overwhelming or threatening, then they probably will not be able to overcome their anxiety and phobia.
But some say this intense exposure is cruel.
I disagree completely, because everything we do in the treatment is decided by the patient, and it is within this time limit a very gradual approach.
There are surprisingly few people, given the suffering that they have endured up until this point, who aren't willing to take that plunge and see if they can overcome it.
People have this idea that you suddenly pick out the animal and throw it in the lap of the patient. That will never happen.
It's teamwork. Erst interviews Mariam for 45 minutes and then describes and prepares her for treatment in an additional 15 minutes.
So I will challenge you to try things, but I will never force you to do anything that you want.
It's critical to determine Mariam's worst fear, what's called her catastrophic belief. Her catastrophic belief is that if a snake is loose and she can't escape, she'll have heart failure.
How certain are you then that you might die as a consequence of that interaction?
Maybe 70%.
70%. Okay.
No one has ever died or become ill either with Erst or Barlow's treatment, but Mariam believes her anxiety won't diminish and she'll escape.
Like run away from the room.
The strong belief in the catastrophe, that is what's driving the avoidance behavior. And the avoidance behavior is the directly maintaining factor for the phobia.
But if Mariam doesn't escape, Erst predicts her anxiety
Would then gradually diminish as we go along in the treatment.
So this is the response prevention that I talked about. So if she wants to run away, he's not going to let her because she needs to be exposed to the snake and see, hey, I'm not having this heart attack like I thought I was going to.
Importantly, there can be cognitive changes.
To help you get new information about that catastrophic belief.
Erst does not prepare patients with relaxation or deep breathing.
I don't think it's necessary at all.
We discovered through systematic research evaluating this component that patients receiving these skills, which
Let's jump ahead a little.
She realizes that her catastrophic belief can't occur unless Erst releases the snake.
I'm not doing that.
After 15 minutes, Erst sits down. Some anxiety returns.
Try to breathe slowly and calmly and with your stomach.
She calms down.
So, what about a name for it? And where are you going?
I'm gonna move here.
Okay. What do you think it feels like?
This is it's a nice snake.
Her anxiety is down.
30, great. You're sitting about, what is this, 3 meters away?
She decides to approach.
Okay, I'm gonna approach you.
Yeah, good.
But hold it.
Yeah,
What psychological principles might account for the improvement so far?
it might be that you have habituation going on, which leads to extinction of the anxiety reaction. You could say that the confidence is increasing, self-efficacy, Bandura's ideas come into play here. From a cognitive point of view, I think what is happening here is that the patient is, with the help of a therapist, accepting to take in new information.
There's also positive reinforcement and modeling. What's Erst's assessment so far?
Deep in my mind, I know it's going to work. That means that I don't have to be impatient. I can be calm.
Certainly, his research supports his confidence. Across several types of specific phobias, even with children, first research shows over 80% improvement compared with control groups, and the results are maintained at a 1-year follow-up.
Well, the research is actually
All right, so we can move on. But eventually well, here, let's see. Eventually she gets very close to the snake, and she will even hold him. So the exposure therapy in this case was successful, largely for the principles they talked about and the behavioral principles that we've covered. She saw that nothing bad was happening, and eventually that builds up your reinforcement history, and you learn, okay, I was around that snake and nothing bad happened. I can do this. Moving on now to talk about modeling. Participant modeling is often used in behavior therapies, and this involves learning by watching. So think back to Alfred Bandura's study with the Bobo dolls. Children watched adults be aggressive, and then when given a similar scenario, the children were aggressive as well. We learn a lot from watching other people and often mimic and enact that behavior. So in participant modeling, the therapist models a calm encounter with the client's feared object or situation, and then guides them through the steps of the encounter until they can do it unassisted. So for someone with a dog phobia, the therapist may hold and pet a stuffed dog while demonstrating relaxation techniques. This allows the client to see the situation unfold and shows them step by step what they can do in their real life if confronted with the feared stimuli. It's often used in assertion and social skills training and in tandem with behavioral research. So behavioral research is exactly what it sounds like. The client practices role playing a different scenario with the therapist, but they switch roles. So the therapist will play the client and the client will play the other person in this interaction. This lets the client learn what they can say and how they can say it. This week's quiz code is rainbow. Now, cognitive behavioral therapy was founded by psychiatrist Aaron Beck in the 1960s, following his disillusionment with Freudian psychoanalysis and a desire to explore more empirical forms of therapy. So cognitive behavioral therapy, or CBT, is a form of psychotherapy that focuses on modifying dysfunctional emotions, behaviors, and thoughts by interrogating and uprooting negative or irrational beliefs. So considered a solutions-oriented form of talk therapy, CBT rests on the idea that thoughts and perceptions influence behavior. So feeling distressed in some cases may distort one's perceptions of reality. CBT aims to identify harmful thoughts, assess whether they are an accurate depiction of reality, and if not, employ strategies to challenge and overcome them. CBT focuses on present circumstances and emotions in real time, as opposed to childhood events. So a clinician who practices CBT will likely ask about family history to get a better sense of the entire person, but won't really spend an inordinate amount of time on these past events. The emphasis is on what a person is telling themselves that might result in the anxiety or disturbance. So a person is then encouraged to address irrational concerns practically and to challenge irrational beliefs, rumination, or radical beliefs or rumination. For example, a person who is upset about being single will be encouraged to take concrete measures, but also to question any undue negativity or unwarranted premise, such as "I will be alone forever," that they attach to this present day fact. CBT is appropriate for people of all ages, including children, adolescents, and adults. There's evidence that CBT can address numerous conditions, such as major depressive disorder, anxiety disorders, post-traumatic stress disorder, eating disorder, obsessive compulsive disorders, etc. It's a preferred modality of therapy among practitioners and insurance companies alike, as it can be effective in a brief period of time, generally 5 to 20 sessions, although there's no set time frame. Research also indicates that CBT can be delivered effectively online, in addition to face-to-face therapy sessions. CBT builds on some of the behavioral therapies that we talked about, but in addition to targeting just problem behaviors, they also target maladaptive thoughts and beliefs. There are many different forms of CBTs, but they share 3 core assumptions. First is that cognitions are identifiable and measurable. Second is that cognitions are key in both healthy and unhealthy psychological functioning. And finally, that irrational beliefs or thinking can be replaced by more rational and adaptive cognitions. So this video just gives a little bit more information about CBT. I am not going to show it here though. This gives you an example of CBT. Again, for the sake of time, I won't show this, but feel free to take a look on your own. So I want to talk now about rational emotive behavior therapy. This evolved from the work of psychiatrist Albert Ellis in the mid-1950s as the original form of cognitive behavioral therapy. So Ellis said, people are not disturbed by things, but rather by their view of things. So the fundamental assertion of rational emotive behavior therapy is that the way people feel is largely influenced by the way they think. When people hold irrational beliefs about themselves or the world, then problems can result. So, the goal of rational emotive behavior therapy, or REBT, is to help people alter illogical beliefs and negative thinking patterns to overcome psychological problems and mental distress. Ellis believed that most people are not aware that many of their thoughts about themselves are irrational and are negatively affecting the way they behave in important situations and relationships. According to Ellis, it's these thoughts that lead people to suffer negative emotions and engage in self destructive behavior. At the same time, humans are capable of challenging and changing their irrational beliefs if they're willing to do the work. So, while specific life events may contribute to mental health issues, REBT therapists believe that it's an individual's own faulty and irrational belief system that caused the most problems. By letting go of negative thoughts and replacing them with positive beliefs, one is better able to accept oneself and others and, in turn, live a happier life. REBT is a short term form of psychotherapy that helps you identify self defeating thoughts and feelings, challenge the rationality of those feelings, and replace them with healthier, more productive ones. It focuses mostly on the present time to help you understand how unhealthy thoughts and beliefs create emotional distress, which in turn leads to unhealthy actions and behaviors that interfere with current life goals. Once identified and understood, negative thoughts and actions can be changed and replaced with more positive and productive ones. REBT can help with negative emotions such as anxiety, depression, guilt, and extreme or inappropriate anger. And this approach is also used to help change stressful and self defeating behaviors like aggression, unhealthy eating, and procrastination that get in the way of quality of life and helping you reach your goals. To help you manage and overcome difficulties or achieve life goals, the therapist works with the client to identify the beliefs and rigid thought patterns that hold them hostage. The therapist will help the client see how irrational those thoughts are and how harmful they can be. Through a variety of mental exercises, the client learns how to reduce their negative thoughts and responses and replace them with healthier, more constructive, and self accepting ones. REBT makes use of a variety of methods and tools, including positive visualization, reframing of thinking, and the use of self help books and audio-visual guides, as well as assigned homework for reinforcement between sessions. Now, we tend to think of CBT as having three waves. So the first is behavioral, the second is cognitive. And the third wave focuses on acceptance. So they stress behavioral and cognitive changes as well, but also focus on acceptance and mindfulness. So instead of trying to change maladaptive behaviors and negative thoughts, the goal is to assist clients to accept and be mindful of all aspects of their experience, thoughts, feelings, memories, and physical sensations. Some examples of specific therapies include acceptance and commitment therapy and dialectical behavior therapy. In ACT, clients are taught to consider negative thoughts like I'm worthless as just thoughts and not facts, and encouraged to accept and tolerate their feelings. DBT is often used for clients with borderline personality disorder and encourages clients to accept and cope with their emotions by making changes in their lives. Third wave CBT techniques have been shown to be more effective compared to placebo or no treatment groups, and probably as or more effective than psychodynamic or analytic therapies. They can be combined with other types of therapies, allowing for the creation of a really individualized plan. CBT and behavior therapy tend to be about equally as effective. And so I like this little graphic here because it shows you, so the green lines show CBT is more effective than no treatment and placebo, but at least as effective as all these other guys. Now, researchers have examined the effectiveness of CBT. Most research finds it to be, as I said, more effective than no or placebo treatment, and at least as effective as these other ones. It's at least as effective as drug therapies for depression. So in general, CBT and behavioral therapy are a pretty good bet and are fairly commonly used for many psychological problems today. In the last section, we will wrap up by talking about group therapy.